This session is all about the positives arising from COVID and explores what we've learned and where we can go with this. Fortunately, I now see that Alison McGregor is logged in, so that's great. Can we, we'll start with David Cumming, President-elect of BAS, consultant spinal surgeon at the Schoen Clinic, previously worked in Ipswich, where he was clinical lead. He's been working with NHS England to develop best practice in spinal surgery as chair for spinal services in the clinical reference group. So he's going to talk about COVID and its effect on these clinical reference groups. So without further ado, here's David Cumming's talk.
It's David Cumming. I'm a spinal surgeon based at Ipswich Hospital. I'm also the CRG chair for NHS England and the president-elect for the British Association of Spine Surgeons. Now, I've been asked to give a short talk with regards to COVID crisis management and spinal surgery and what's happened over the last year, and perhaps what we can learn from it and where we should go forwards. So really what I'm going to talk about is the NHS England phases of response to COVID-19, some of the guidance and documents that we were involved in, the surgical prioritisation, what perhaps we can learn and maybe how we can do things better next time, or perhaps how we can learn from what we've done and use that as a change of practice to improve patient care. So the first phase really began in March 2020. So at this point, there was some key principles which we were all asked to do within the NHS. This was to free up the maximum possible inpatient and critical care capacity. So really at this point, we started postponing all non-urgent elective procedures. We were advised to discharge all medically fit patients from hospitals, and there was a block purchase agreement with the independent sector for their capacity. We were also asked to prepare for and respond to the anticipated large numbers of COVID-19 patients who would need respiratory support. And this was done by enhancing oxygen supplies and distribution, a national procurement of ventilatory systems, national procurement of PPE, and segregate all respiratory patients at point of admission to hospital from other patients attending for any other reason. We're also asked to support staff and maximise their availability. So we had to enhance wellbeing for staff, remote working where appropriate, targeted testing, and redeployment and maximising staff as required. Phase two really started towards the end of April, where we're now asking for all NHS local systems and organisations working with regional colleagues fully to step up non-COVID-19 urgent services as soon as possible over the next 6 weeks. So at this point, surgical prioritisation was created. Cancer care was to continue and return if reduced to pre-pandemic level and ring-fenced capacity. And this is where the independent sector has been particularly useful with ring-fenced beds for cancer care. Referrals, diagnosis, treatment to be brought back to pre-pandemic level. Hospitals to prioritise cardiac service, including surgery and PCI and PPCI. All high-risk patients to be contacted and educated on specific symptoms to look out for and when to contact and escalate to hospitals, and a daily review of all inpatients, sure that there was no delays to discharges. The third phase really happened towards the end of July, and at this point we're accelerating towards the return to near normal levels of non-COVID health services, making full use of the capacity available in the window of opportunity between now and the winter. At the same time, we were advised, or certain hospitals were advised to prepare for winter demand pressures alongside continuing vigilance in light of further probable COVID spikes locally and possibly nationally. And during doing the above in a way that takes account of lessons learned during the first COVID peak. So we were advised to lock in beneficial changes, look to explicitly tackle fundamental challenges, including support for our staff, action inequalities and prevention. And really, this is the point where we're advised to try and learn from what happened in the first wave and try and embed some of those principles and continue some care if we could over the winter. Obviously, there was vast regional variation in the first wave, and there has been in the second and third wave since that time. Phase 4 was really around November, December 2020, And this was really a return to incident level 4, which is very concerning. This was a return to activity and preparedness as per the first wave. The principles were to respond to COVID-19 demand, put all the stops in the COVID-19 vaccination programme, maximise capacity in all settings to treat non-COVID patients, responding to other emergency demands and managing winter pressures, and supporting the health and well-being of our workforce. So how have BAS been involved in this during this time? So BAS has worked with the CRG and worked with NHS England, along with the BOA, SBNS, and other specialist societies, including specifically rheumatology and pain management. So we did develop the clinical guidance with regards to spinal surgical services during and after the coronavirus pandemic. And there is a link here, which was on the BAS website. And this was published in May 2020. And this was something that we worked as an executive and with GIRFT as well. And the key was that we were trying to look at a system where we could scale up and scale back down again according to demand and pressure on the system. So this was recommending local imaging for emergency referrals 24/7 with consultant review. Obviously, this is very difficult to implement, and there was issues with regards to this. But the idea was we wanted to stop moving patients around as much as possible. All surgeons were to prioritise elective waiting lists as per national guidance. All surgeons were to assess each patient on the waiting list as per their known risk factors, and when possible, consultation be done remotely using the available resources. And we all know the challenges this has brought, but there are certainly some patients who have benefited from remote consultations, and some patients who have been very happy and have welcomed that contact. Elective patients were to be consented as to potential risks of coronavirus and the risks of coming into hospital at this time. Elective patients to be advised on self-isolating or shielding before and after surgery, and elective patients were to be tested for coronavirus, as they still are, usually roughly 72 hours prior to surgery. Also, regular screening of staff and surgeons in protected areas, and spinal injections for severe radiculopathy only. We then went on to develop some guidance with regards to consent during coronavirus, and obviously we felt that this was important, so the patients were fully aware of the risks. Other societies have done similar things, and this is the link to the consent form that we developed. And then the last part, which was particularly relevant back in May of last year, because there was a lot of concern around steroid usage and some degree of immunosuppression with regards to with steroids. We developed some guidance with regards to spinal injections and what we should inform the patient, and what was appropriate, not appropriate at that time. And again, the link is here, which is on the BAS website. So onto the clinical prioritisation. So this has been overseen by Nigel Mercer, who's in charge of the Federation of the Surgical Specialty Associations. Now, as BAS, we spoke to him very early on, because we did have some concerns, because spinal surgery did not have its own section within the prioritisation. We were advised that this was because we do not have an SEC. However, what the agreement we came to was that spinal surgery would be put into both neurosurgery and orthopedic surgery to make sure that anybody looking at that list could pick out the conditions that we were concerned about. And I think since that time, it's revised on a monthly basis, and I think it has helped ensure that we prioritise our patients. So the categories are P1A, less than 24 hours, P1B, less than 72 hours, Priority 2, less than 1 month, Priority 3, less than 3 months, and Priority 4, greater than 3 months. Now, obviously, over time, this is patients' care has been stretched with the lockdown, with the reduction in elective services, and I think that's why it's vitally important that we still contact our patients, and we are in contact with patients, particularly those who are at risk of deteriorating, and making sure that we are prioritising their care. So from a spinal surgical point of view, the Priority 1As were cord equina, cord compression with neurological dysfunction, and myelomeningocele. The Priority 1B was spinal trauma requiring stabilisation without neurological dysfunction, and the Priority 2 were degenerative spinal conditions with progressive neurology and spinal tumour surgery. The P3 was spinal surgery, either injection or decompensative for intractable radiculopathy and childhood adolescent spinal deformity. And then your priority 4 are your degenerative spinal diseases such as spondylolisthesis or spinal stenosis, where there's no significant deterioration and where these patients are stable and there's no current concern with regards to deterioration. Also adult spinal deformity surgery with progression and congenital spinal deformities were placed in this group as well. So some of the other things that we did during this time is that we worked closely with the MSK services within NHS England, and there's some very good stuff on their website with regards to the NHS Change Challenge and the Best MSK Health. And we're working with Andrew Bennett, who you've already heard from, and we're working very closely with the MSK services and with GIRFT and with all the other specialist societies to make sure we develop what we feel is best practice for patients to ensure that now we have extremely long waiting lists, that we try and deal with these in the most appropriate way and make sure that we streamline services and get the best care possible for patients at this time. So ideas were submitted during COVID with regards to best practice, and some of the things that came up were so imaging clinics for deformity, so making sure that x-rays were performed ahead of time when patients were free to turn up to have x-rays done outside of clinic time, and then a lot of these children and parents were contacted by phone to discuss their x-ray and discuss their clinical condition. Virtual MDTs, so we felt it was vitally important that primary, secondary care triage systems continue to work closely together. A lot of us run face-to-face MDTs with our primary care ESPs and practitioners, and we've realised actually doing these virtually has been of great benefit. We can share the images online, we can talk to each other more easily and be more inclusive. Also regional MDTs. So previously a lot of people, we've been stuck with seeing people face-to-face at regional MDTs once or twice a year, but now we can do this virtually, and certainly east of England we set up a regional MDT every couple of months to discuss interesting and complex cases. So what can we learn and improve? So I think what we've learned is that networks are very important, but certainly NHS England has shown this with regards to critical care and other key services like neurosurgery and cardiac. And we feel that spinal networks are key at this time, that we need to formalise them and we need to work together as a group to make sure that we're providing best quality care and that actually patients across a region are being treated in a fair and equal manner. We feel it's important that we define clear pathways and define clear triage systems for patients to get into spinal pathways, and make sure that the patients that we're seeing as consultants are the most appropriate cases for us. We've realised that we can do some things remotely. Clearly, we can't do everything remotely. But there are some things some conditions and some cases where we can talk to patients remotely, share the images on whichever system you wish to use, and keep the face-to-face appointments for what is most appropriate for those patients who really need to be seen face-to-face. And we need to continue to use technology to improve our MDTs and also improve education across the board and use more of these technologies to make sure we spread the education across the board, similar to what we're doing today. Thank you very much.
Okay, apologies to all. It looks like our moderator has accidentally dropped out. I now have Lee Breakwell just to introduce the next speaker.
Thank you, Henry. Apologies to everybody who's in the meeting and having problems accessing, and for Patrick having technical issues. Obviously, they won't hear me, but many apologies to those who aren't in the meeting. we're having problems with ticketing. That's being sorted slowly. I'm sorry, Henry, but thank you for admitting me to do this. So the next speaker is Andrew Bennett, who was suggested by David Cumming as a colleague who works with him on the CRG. He's a clinician, he's a very senior physiotherapist, so understands the clinical aspects, but is now a senior commissioner at NHS England and has been involved in the planning that David's alluded to as to how we get through COVID and beyond into a more positive area. So over to Andrew Bennett. Thank you.
Hello, my name is Andrew Bennett. I am National Clinical Director for Musculoskeletal Conditions within NHS England and Improvement, and I'm also a consultant physiotherapist within Sutton Health and Care Alliance, hosted by Epsom St Helier NHS Trust. Now, I'd like to thank you for this privilege and opportunity to present in this COVID crisis management session regarding our national response from an MSK perspective to the pandemic, and also to introduce our new programme, Best MSK Health, in the context of restoration and improvement. Now, prior to the pandemic, in January, February last year, I was new to the role of National Clinical Director, and within this context, we produced a vision for MSK conditions moving forward, and that is to promote lifelong best MSK health within all communities. MSK Health enables physical activity and our ability to move, do dexterous activities and participate in all aspects of life, helps us grow well, work well and age well. Physical activity also helps all-cause mortality by 30% and helps prevent and manage a wide range of mental and physical health disorders. And our ambition is to enable MSK Health, enable physical activity, help people live life to the full and address the known inequalities in MSK Health that we have moving forward. And we want to do this through the sustained delivery of evidence-informed, personalised, high-quality, integrated healthcare value to all. And there's lots of buzzwords there. In terms of evidence-informed, research needs to inform what we do, but so does expertise and experience. Our provision needs to be personalised. People need choice and control over what the healthcare they receive and how it's delivered based on what matters to them. And at the heart of that is shared decision making. Our provision needs to be high quality, safe, effective and associated with a positive experience. And this should lead to social value where everybody involved in MSK provision values what is delivered. We also need to achieve economic value, making best use of our constrained resource to deal with the challenges we have. And we need to optimise our environmental value and our carbon footprint moving forward. But key to this is the model of integrated MSK healthcare. And this is built to deliver this vision and aim, but to account for variance in resources and population need locally. It's based on the principle that musculoskeletal conditions are driven by a multiple of biopsychosocial factors unique to the individual. The majority of MSK conditions can be adequately managed in primary and community care, where we can help people best live with MSK conditions and live life to the full. We need the right triage in place to enable those a smaller number of patients who need to go to secondary care to get an appropriate and timely referral and to get the right intervention in secondary and indeed tertiary care enveloped in a rehabilitative model to enable physical activity. Now, accounting for the multiple biopsychosocial factors driving MSK conditions, we have to work within this model, with our health and social care services, mental health services, and the third sector. And so this model aligns with the principles of triple integration, and it's aimed to provide a framework to hang best practice guidance and pathways to optimise the quality and value of our provision. Now, we entered the the COVID response phase in approximately February and March last year, and we took this principle of an integrated model of MSK healthcare and to avoid silo-based working where primary, community and secondary care, the third sector and other local services aren't connecting, into our strategy for responding to the COVID pandemic. We rapidly convened a MSK COVID group to facilitate collaboration between the professional bodies, arm's length bodies, charitable bodies, and the intrinsic programmes within NHS England improvement that drive MSK around the objectives to support surge capacity, maintain urgent emergency provision, and reduce transmission. And this COVID group had an advice and guidance function and a task and finish function. And we applied this integrated model of healthcare to ensure that our messaging was aligned across our various messaging resources, but also to ensure what we were putting out with regard to prevention or to primary community care, diagnostics and secondary care services synergised and aligned, and the messaging was coherent to avoid a confused message from an MSK perspective in already a challenge and complicated situation. And I believe we did that quite well. And as we moved out of the phase 1 response into the phase 2 response, where we were looking at a degree of restoration of services and isolating and identifying beneficial changes to lock into our strategic planning, our overarching beneficial change was the application of this integrated model and the collaborative and indeed co-productive approach that we had built through our response. And we took that forward specifically in the Change Challenge project, which was our ability to use a crowdsourcing resource to go out to the MSK community through a focused campaign to ask people in community services, pain management services, rheumatology, trauma, orthopedics and spinal services, what changes had been rapidly brought in the context of the pandemic that we wanted to keep and immerse in our strategic planning moving forward to optimise the quality and value of our provision. And we were really able to build on this integrative and collaborative model by really driving forward a co-productive approach, working with our charities, but working with our colleagues in the lived experience team and a number of patient and public representatives, not only around this Change Challenge project, but to identify themes of what matters to the MSK population moving forward to help drive our strategic planning. And these beneficial changes work, but also the themes of what matters work, has been used not only to drive our MSK strategy, but to inform other elements of the NHS strategy moving forward. Now, this approach to MSK, I think, raised awareness of the value we could bring, and this is evident in the letter published just before Christmas with regard to the operational priorities for the winter and 2021-22, where key areas were identified where it was perceived that there was the greatest opportunity for improvement in the context of respiration moving forward. And those clinical areas were ophthalmology, cardiac services, and of massive value to us, MSK and orthopedics. And this has led to the rapid development of a programme for MSK called the Best MSK Health Programme within the overarching Pathways for Better Health programme in NHS Improvement. And this presents a significant opportunity to sustain an integrative, collaborative, co-productive approach, not only to our restoration challenge, but our challenge to improve MSK services moving forward. So the challenges for this programme are to address those pre-pandemic challenges that we all know. We have a challenged MSK system before the pandemic. Rising demand, constrained resources and increasing complexity. We know that we had unwarranted variation in commissioning, access and delivery, and provision was as a consequence complex, fragmented and variable. And this was driving inequalities in MSK health. Then we've got the unintended consequences of the pandemic. The health and well-being of the population have been massively affected from a biological, a physical and social perspective by the pandemic. And that is increasing the complexity of patients that are presenting to our care. We know that waiting times have gone up because of the pause to plan care that we've had to undertake. And this triad of issues is widening health inequalities. We also know that we have a workforce that is fatigued and a population that's fatigued. And this is complicating the restoration challenge we have. But we've got these beneficial changes of integration, collaboration, co-production, as well as the local changes, the principles of which that have been shared across our Change Challenge sites. And we are now moving from a response phase with a light at the end of the tunnel through vaccination into a team and a number of patient and public representatives, not only around this Change Challenge project, but to identify themes. Now, this approach to MSK, I think, raised awareness of the value we could bring, and this is evident in the letter published just before Christmas with regard to the operational priorities for the winter and 2021-22, where key areas were identified where it was perceived that there was the greatest opportunity for improvement in the context of respiration moving forward. And those clinical areas were ophthalmology, cardiac services, and of massive value to us, MSK and orthopedics. So the key drivers of this programme is to sustain co-production right the way through our regions, integrated care systems, and locally in our recovery improvement strategy. We do need to have a top-down approach working with the regions and ICSs, but most importantly for me, we need to enable our local leads to drive restoration improvement, informed by local knowledge of resources and population. We need to optimise the local integrated delivery models, utilising some of the virtual beneficial changes to integrate across primary, community, and secondary care. We cannot work in silos. On that, we need to consolidate our evidence-informed condition-related pathways and guidance, and we need to really focus on supporting people best live with long-term conditions in the community. Digital enablement and measurement of quality, value, and impact across the model, and also across the pathways, aiming for top quartile of performance, is key to help deliver on the massive restoration challenge we have and improve services moving forward. So we've got this programme, and this is new, I can't talk through exactly this strategy, what it is yet. And we are stealing a slide from my colleague, Chris Mercer, and our launch presentation last week. The best way to describe this programme is like an aeroplane that we're trying to fly as we repair and rebuild. And to do that, we all need to take part in it, and we all need to share the responsibility for restoring and for improving MSK services. And I think through this programme, we have the unique opportunity which we've never had to do that. And so I draw you to the programme launch, which goes into greater depth, particularly around the orthopaedic and the community services challenge, but also the future site where we've already got some products in the context of restoration, such as our restoring primary and community MSK service principles, which goes through this model for integrated service delivery. This is a pre-published document, which we hope to bring out in a couple of months, but is accessible via the future site, and I'll encourage everybody to have a glance at that. We've got a massive challenge ahead, both in the context of restoration, but improvement. But we've got a vision, we've got an aim, and we've got a programme and resources to help do something different. And I hope collaboratively we can rebuild a new normal in MSK, focused around this vision and aim for delivering best MSK healthcare for all. Thank you for your time, and I very much look forward to answering some questions at the end of this session.
Okay, thank you very much, everyone. Our chair, apologies, seems to having a little bit of trouble with his audio. Next up is Alison Bennett, who will be talking on, Alison McGregor, my apologies, on medical schools and training.
Henry, can you hear me?
We can hear you now, Patrick. Thank you.
Great. So I'm finally back in the picture. Thank you very much. So I'll just give Alison a little introduction. She's a professor of musculoskeletal biodynamics in Imperial College, where she manages the Human Performance Group, trained as a physiotherapist in King's College Hospital up to 1989, then biomedical engineering in Surrey, doing a PhD on spinal mechanics at the Royal Postgraduate Medical School. She led a program of research into rowing performance with a focus on rowing kinematics in association with the GB rowing team, contributing to their success in the London 2012 Olympics, in which she was also a torch runner. But most importantly for this session, she's Director of Undergraduate Services for the Imperial College Medical School. So she's going to talk to us about the impact of COVID on medical school intake and how they deliver medical training. Thanks very much.
Good morning, everyone. My name's Alison McGregor, and I'm the Director of Undergraduate Research at Imperial College School of Medicine, and I'm also a professor there doing research in musculoskeletal biodynamics. I've been asked to just give you a little bit of an overview of what it's been like teaching medicine through the pandemic and trying to actually do some research during these interesting times we've been in. It's really been very different as we've been in the different phases of lockdown and the remits of the pandemic. We are still in the stage where most of us haven't been into an office to do our work for over a year now. And there is actually probably no clear time when we will go back into our normal working until possibly next year. So we look at teaching first. So when lockdown came in, the universities actually closed a week before lockdown actually happened, and it brought an end to all face-to-face clinical teaching, all face-to-face lectures, and any clinical skills or practical implications for the students. So very rapidly we had to convene a way of progressing to digital learning. We already did a mixed mode learning approach anyway, but suddenly we became reliant on a range of different platforms. And of course the college preference was Teams, because they felt that at that stage there were security issues with Zoom, and that caused all sorts of problems because I think the opposite was happening in the trust. And we had to look around governance of doing patients and doing ground rounds where any patient information was presented, and how we got around that and got consent for it. But it meant that students could be taught their more theoretical or aspects of their skill knowledge online, but actually they weren't going to see patients, and we had to be quite creative. We optimised use of an online resource called Capsule, which had lots of patient databases. We had existing virtual patients that we could tap into, but we also turned to technology, and some of the clinicians engaged with the HoloLens techniques which they'd already been using in a more research way rather than an actual teaching way. And we found a mixed reality way of delivering teaching, either using the HoloLens to create grand rounds or ward round scenarios that students could engage with, so they could see the patient and they could be in the room without physically being in the room. And we did this mixed model of simulations where we could bring patient details and clinicians talking to patients. So that was the first lockdown. And one of the other things that our students did was volunteering, and they created a whole range of volunteering activities, from community activities to feeding NHS workers and all sorts of things that were permitted with the remit of the lockdown. So then, of course, things changed for all of us, and we were faced with this, excuse me, this new reality where everyone's interaction was through this kind of platform of seeing faces and talking heads, as I quite often speak of them, and this presents its own problems. So one of the biggest things we've had in our student feedback is, what will I do to make students turn their cameras on? And of course that's actually something I have, because of privacy laws, I have no ability to turn students' cameras on. So it's kind of interesting thing that the students feel that everyone should have their cameras on, but they actually can't always do that. And then of course we're limited by people's access to internet bandwidth. We all know from these kind of meetings that as soon as you have live stream coming into your calls, and the more people you have on those calls, the more your internet will fail. And we currently have students accessing our courses from all around the world, China, America, Australia. So actually scheduling teaching at a time that everyone can access is problematic. Scheduling exams is even more problematic. But sometimes with some nations, actually they cannot get the bandwidth to join us and put their cameras on. So I have had the interesting experience of telling students off without actually being able to see them on how they react. And of course, we've now inherited this new language. It's basically you're on mute, you haven't turned your microphone off. So I think it's lent to a lot of changes in behaviour. Since the first lockdown, things actually dramatically changed because it became quite clear to the medical school leaders that this was not going to be a short stay and that we were going to have problems graduating our medical students. So our first issue had been that within a week of lockdown, the first lockdown, we were supposed to deliver medical school finals. So we rapidly found a way of delivering these online that actually still demonstrated that the students had the skills and the knowledge and the abilities to be safe as a doctor. And actually that went surprisingly well. But also the Medical Schools Council soon got on the case quite early and said that actually we need to have these students in clinic. So very quickly throughout the summer, I think it was in May, according to the letter I put here, medical students finally got categorised as key workers, which meant that we could start reintegrating them into trust placements. The problem, as you all know, is that trust placements perhaps were not the same and the learning opportunities weren't the same. So we've had to work out a way of still maintaining the use of the online materials and having this mixed mode of teaching, of them joining clinical placements when they can and doing the other things as and when we can deliver it online. We've also been able to, in the current lockdown, we're allowed to continue with teaching that cannot be delivered remotely. So we are still doing things like communication skills lecturing, anatomy and clinical skills teaching. Everything else we are doing online with the other years. So it is very much a mixed bag. We know that some of the experiences aren't as good as they could have been. At the start of this current pandemic in January, we also looked to redeploy medical students to help with the front line, and this had, I think it's best to say, mixed reactions. There was a lot of anxiety from the students, probably even more anxiety from their parents, especially if they were overseas students, about actually being embedded and working in the hospital. And of course, the vaccination issue has been a problem, but now their key workers, those who are having clinical contact, have now been vaccinated. But we've had all sorts of problems with redeployment, and there have been issues on Twitter that I won't go into now, but happy to answer questions on later. We've made all exams online, although medical school finals are going ahead as paces and will be in-person exams, but getting examiners at a time of clinical need has been again problematic. So teaching has been a roller coaster with lots of different issues, managing breakouts, managing social distancing within classes, and also getting students to comply with some of the social distancing. So they're very good most of the time, but then when they get inside the medical school building and it becomes out of class activities, it's quite easy for them to forget and not wear their face masks or not respect the social distancing. And you know, the practices of practicing for finals on each other has been difficult for them to comprehend and not be allowed to do. So I think we've been creative. We're having to find solutions, but like I say, it is very much a continual roller coaster that we're never quite predicting what's happening next. So finally, just to talk about research and being someone with an active research group, again, it's been a process of change and adaptation. And I've kind of used this image because I think it's just like there's glimmers of hope, but I think research has taken quite a pounding. I think we've had to change PhD projects, we've had to change student projects. So our undergrads do a compulsory science year. We had to be quite creative and get them thinking about creating research projects and doing grant applications rather than writing up research they weren't able to do. Labs for us only started opening up in the summer unless you were developing vaccine or other diagnostic methods. And even then the lab access is limited, it's very social distance, it's with extra precautions, you have to book slots. And it took a long time for ethical approval to be reopened for anything involving clinical subjects. And again, recruiting patients into studies at a time of lockdown is kind of complicated and people are very resistant to come in, as you can imagine. So I think the future for some clinical based studies and studies that involve participants is still quite bleak. Obviously, the financial implications of the pandemic have made funding become even more precarious, and I think we have a lot of PhD students who've had to make adaptations to their PhDs. We've had master students that may never have been on campus. And we have postdocs who are struggling to deliver on their grants because they haven't been able to do the work, or they can't get the components or the electronics to build the systems that they need for their research. So we see sprigs of hope in research. It's starting to open up. I think the long-term future and how we secure funding and conduct clinical research will have to be rethought. But we will keep trying to survive, and all you can do is adapt. So thank you for listening. I hope some of that's been useful, and I believe we'll be able to answer questions later. Bye-bye.
Good. Thank you very much, Alison. Lots of interesting questions arising from that. We now go on to the perspective of trainees in spinal surgery. So we asked Zach Silk, who's the outgoing trainee representative to BAS and is a post-CCT fellow in spinal surgery, based in Stanmore at the moment, but having completed fellowships in Leeds, Great Ormond Street and USA. And he kindly agreed to fill us in on what it's like at the coalface from the spinal surgeon in training. So we'll move on to Zach Silk. Thanks very much, Zach.
It's a real honour to be invited to take part in this morning's session. I've been asked to talk to you today about the impact COVID-19 has had on surgical training, but not just focusing on the negative implications. I actually plan to highlight some of the opportunities available that one couldn't imagine possible, because until now, we never had a reason to change the traditional models of training. I'm planning to use this as an opportunity to spark some thoughtful discussion about what we can all do to optimise things going forwards. For those of you who follow Twitter, many of you will have come across this hashtag, started last year during the first lockdown. No training today, no surgeons tomorrow. Scary thought, right? We all know it takes years to develop the surgical skills and experience expected of a consultant surgeon. You add in the complexity of a subspecialty like spinal surgery and the fact that most of this training takes place in post-CCT fellowships, it becomes clear that surgical training must be prioritised across the board, because one thing is for sure, both patients and our regulator, the GMC, would never accept a drop in standards. And so if there is one key take-home message from this talk, training has to be a priority as we come to tackle the ever-increasing waiting list during the recovery phase. But aside from the impact on logbook numbers, COVID has also affected training in many other ways. Courses, conferences, exams were all cancelled, and those at transitional points in their career found themselves stuck within an ever-tightening bottleneck. The cracks are starting to show. Morale is extremely low, and this is impacting trainees' mental health and well-being. But of course, it would be wrong to assume surgical training was the best it could be prior to the start of the pandemic. It was widely recognised that policies such as the European Working Time Directive had negatively impacted on trainee experience over the last decade. With the introduction of mandatory rest periods, which were intended to improve work-life balance and patient safety, practically this meant less boots on the ground. Over time, this gradually led to a loss of the firm structure and a greater proportion of trainee time spent providing out-of-hours care and covering rota gaps, all of which has meant less time in theatre. As a result, we've seen a greater need for acquisition of surgical experience during post-CCT fellowships, and add into the mix the 2016 junior doctor contract with restrictive rota management rules, it makes it much more difficult to prioritise time for training in craft specialties. Yet there is one silver lining that may come to benefit trainees in the post-COVID era, and that's the increasing use of the independent sector for treating high volumes of low complexity patients. Just by way of example, the Royal College of Surgeons, amongst other training organisations, have been calling for greater access to the independent sector for many years now. And in this position statement, which was published prior to the pandemic, we can see a number of the challenges highlighted along with the potential solutions, yet politically it was never widely accepted or implemented, and some of the issues they described then still stand today, such as ensuring GMC approval for training and agreeing contractually with independent sector providers as to who provides indemnity cover and funding for this training to take place, there's also the other aspect of who provides cover for service provision at the base hospital. But as we've seen in other areas of healthcare delivery, out of every crisis, there's an opportunity. Towards the end of 2020, both the JCST and Health Education England published their guidelines for ensuring this drive now becomes a reality. And although there is much to do to ensure this guidance is more widely implemented, the political will is very much there now, and TPDs up and down the country will be looking at ways to firmly embed this in their training programmes. For those of you who provide clinical or educational supervision to trainees, I really do recommend downloading a copy of this recent guidance from the JCST. They discuss a number of strategies to maximise training opportunities going forwards, many of which you'll already know, but it provides the mandate to really push this message home. Every case is a training case. They highlight some of the practical steps that you might use, such as introducing your trainee at the team brief and their role within a case, ensuring the theatre team are on board from the start of the day, and encouraging the anaesthetists to do the same for their own trainee. But they also discuss some of the additional support required for trainers. One thing they've also come to recognise is the important role online education will have going forwards, and this is an area that I've developed a particular experience in over the last year. The pandemic created a huge vacuum. Trainees were suddenly redeployed and regional training programmes cancelled, and for consultants there was no way to access relevant educational materials for CPD. So along with Sasha Nahuja, Rohit Shetty and Rajat Verma, we set up the BAS Education Series, attended by hundreds of delegates in the UK and abroad. And since then, we've developed a trainee-focused webinar on fellowships, and we've fully established the Case of the Month series, which is providing the opportunity for training units around the country to deliver surgical education to a much wider audience than would ordinarily be possible. We've also come to learn that the interactive tools, such as polls and the Q&A facility within these platforms, could help make this method of teaching much more enjoyable than previous. Prior to the pandemic, doctors in training often travel for miles to access regional teaching programmes. But since the shift to online, no longer do trainees have to choose whether to stick around for an interesting case or leave for teaching. They're able to access these talks in their own time, and it also provides the opportunity to develop a nationally coordinated approach to training spinal surgeons, which is something that Niall Eames and the STIG Development Group have long been working towards. The pandemic has also prompted a radical change in the way professional exams are delivered. Courses geared towards helping trainees pass these have had to shift online at a much reduced cost to delegates. And having had experience of teaching on a number of such courses, I think they're great for Viva practice. It's also now practical to also invite a large number of observers without impacting on the quality of the course. One area we've yet to see become more mainstream is the use of intraoperative recordings to educate surgical trainees. And this is not a new concept. Live surgery at conferences or even on TV has been around for years, but in the past it's been expensive. It's often involved a large TV crew in theatre, and this is impractical on a daily basis. But now we have relatively inexpensive but equally high definition technology with two-way communication available between surgeon and trainee. It reduces the number of people in theatre, provides trainees with the opportunity to also get a head start so that they can watch how a case is done before doing one themselves. Just by way of example, data-secure platforms have been designed specifically to meet this need. And not only does it provide the means to educate trainees, but it also provides a facility for other surgeons to contribute to an operation live. Finally, the pandemic has also changed the way we all work. Trainees now have the ability to remotely access hospital systems in a way that could never be imagined before. Some of the benefits have included a reduction in travelling time to and from work, meaning more time spent at home with family. But another benefit has been the ability to use personal space for work, something of a real scarcity in many NHS hospitals now, and I feel in the long run this will help to improve both mental health and well-being. Whilst virtual clinics have become the norm, the obvious downside is a reduction in face-to-face contact coupled with a reduction in time spent with trainers. But as we've become more experienced with this, the benefits are much clearer. It's much easier to separate out routine follow-ups that offer very little educational value from more interesting cases that require time, both for assessment and training. And although the use of recorded clinics for feedback hasn't been widespread in hospital medicine, it is in general practice and has been shown through countless studies to improve the ability of trainees to take histories and communicate better. Perhaps this is something we will also see implemented in surgery with time. So to conclude, surgical training cannot wait until the pandemic is over. And whilst the impact on doctors in training has been particularly hard, this crisis has finally provided a strong enough reason to drive home a number of improvements in surgical education across the board. I really invite you all to seize this opportunity to make a difference and to consider every case as a training case. Because remember, trainee today is a colleague tomorrow. I thank you once again for taking the time to attend today's session and for listening to this talk.
Good. Thanks very much, Zach. That was tremendous. So we've got a number of questions in the chat room, and I'm going to put them forward. The first one was from Mike Grevitt, and this is to Andy Bennett. So have we got Andy Bennett? The question is, what's the vision for regional spinal networks in delivering quality improvements?
Hi there, Andrew. If you could turn on your microphone.
I'm not.
We're almost hearing you, Andrew, but not quite. Oh, good. We can see you, but we can't hear you.
You're muted, Andrew.
Can you unmute?
Yeah, I'm off mute.
Great. Good. Did you hear the question?
Go on, repeat it.
It was about the way regional spinal networks might interact to provide quality improvements in your planning.
Yeah. So it's really, so we have split the program into a set of work streams. One of those work streams is the restoration optimization of spinal services, led by our GIRF lead, Mike Hutton. There are a number of other work streams which sort of come together as a Venn diagram to interact. Now, within that, we need to formulate an overarching network for MSK, which we don't have, but that then has to link with the spinal network because it's a significant element within our MSK strategy. So we are working out how to do that at the moment. And moving forward, we will make sure that there is a degree of integration through that spinal work stream.
Brilliant. Thanks very much. The next is to Alison, and it's from Aprajay Golash, who asked, how did HoloLens help more than standard video conferencing like Teams? Have we got Alison?
Yes, I'm here now. Hopefully you can hear me.
Okay.
We actually used it to create virtual consultations. So the clinicians who could go in and see the patients did it with the HoloLens, and the students accessed it remotely so they could have virtual consultations with patients. And it's also being used for teaching skill acquisition as well. So the member of staff will wear it and show how things are done, either in an operation or a procedure that's going on in a hospital, and it can be remotely transmitted to the student. And so it's a more active way of getting them involved in the actual interaction without them being physically in the room and risk the spreading of infection.
Excellent. Then we've got a question from Paul Thorpe, which you'll be able to distance yourself from, Alison, because it's about Bristol Medical School. It says, my daughter started medical school at Bristol this year, and my honest opinion is that the first year students appear to have been largely abandoned by the medical education network. We entirely recognise the difficulties introduced by the pandemic, but as frontline doctors, we have all made huge efforts to modify how we work, but still provide the best quality of care. From the feedback I have from my daughter and many other families with medical students studying presently, the universities have not stepped up to the plate in the same way as the wider NHS.
I suspect that's very true. I mean, certainly we've had ours coming in, so that's been quite unusual. It's been very difficult because we're down to 20% capacity, and lecture theatres that normally take 300 are down to 50 students only. So for us, we've had to deliver sessions 5 or 6 times to get through the whole quantum of students we have. And I just think every medical school and every university has approached this problem differently. We were active campaigners to get medical students recognised as key workers. So I suppose we've taken quite a different stance, and we made a particular effort for first years because it's their first year at universities, that it's their chance of making friends and cohorts. So we work quite hard to have them physically coming in for some of the time in the first term and subsequently. And we have been criticised for bringing them in to teach anatomy when some people are saying, why didn't you do it online? That said, our infection rates in the university are exceedingly low. And I suppose it's always a compromise because we've pushed to get students in, other universities haven't. But the friction you get both from some family members and some students and also some staff about coming in to teach or be present in teaching session has equally been a whole whirlwind of a journey. So I don't think there's any perfect situation where you keep everyone happy, and that seems to be the story of my life, not keeping people happy.
Thanks, Alison. I'm sure it's a desperately difficult tightrope to walk. Next question is from Neil Orpin. I particularly enjoyed Zach's talk. Please consider the private sector available for training opportunities. Discuss with surgical reps where surgery is actively being done, and I welcome being contacted any time to facilitate surgery. Would you please encourage trainees to know about these opportunities and push for them to happen? So a comment, perhaps more than a question. Well, that's the lot, and that brings us up smartly to time. So I want to thank all the speakers for taking the effort to make the talks, get them online. Very stressful, much more than a normal meeting. You all really stepped up to it. I want to thank you very much. You blazed the trail, and everything from here must get easier. Thank you very much.